Dr. Anoop Misra. He needs no introduction. He is Executive Chairman of Fortis CDOC Hospital at Diabetes and Dialysis Center. He is Director of National Diabetes Obesity and Cholesterol Foundation. He is President at Diabetes Foundation of India and he is former Professor of Medicine of All India Institute of Medical Sciences, New Delhi. The major achievements are he has more than 300 published research papers and he has been analyzed by Stanford University to be among the top 2% scientists in diabetes from India ranked globally. He is editor-in-chief of Diabetes and Metabolic Syndrome, Clinical Research and Review, and Clinical Keys. He is associate editor of Journal of Diabetes, USA, European Journal of Clinical Nutrition, member of Academic Board of British Medical Journal, member of the Lancet Commission on Obesity 2023. He has got Padma Shri Award by President of India in 2007 and BC Roy Award in 2006. He has authored a book on diabetes with delights, English and Hindi. He will be talking about non-obese lean patients with diabetes heterogeneity and phenotype, implications on management. Over to you, Professor Dr. Anoop Misra.
Thank you. Thank you, Dr. Saurabh. It's my honor to present this particular topic here in front of you and the audience. Can you see my slides, please? Are my slides visible?
Yes, sir, your slides are visible.
Okay, just give me a moment. I'll just have a pointer option. Okay. So in next 20 minutes, I'll illustrate this important topic, which is actually very, very important as far as the Indian population is concerned, non-obese lean patients with diabetes. Now, there's something which people outside the country, Western countries, don't see very often. So here on the left side, you see two mice. One is the obese one and one is the lean one, and this will remain as the backdrop of my presentation. A little bit of background, definition, and questions. In several parts of India and in clinical practice, many Indian patients with diabetes are non-obese or lean. We are going to focus on non-type 1 and non-elderly patients here. A number of confusing names have been introduced: malnutrition-related diabetes, protein-deficient pancreatic diabetes, Jamaica type diabetes, J-type diabetes, M-type DM, type 3 DM. But overlapping categories were first lumped together by MMS Ahuja, and experimental evidence was provided by GS Bajaj. And so the name given at that particular point of time, around 4 decades back, was ketosis-resistant diabetes of the young. These patients had a very high fasting blood glucose, onset of diabetes less than 30 years, the BMI, which was very low. They belonged to poor socioeconomic strata, had childhood malnutrition, and insulin requirement was very high. This was initial presentation of this type of diabetes. Now, there are confusion reigns as far as terminology for non-obese, as far as lean is concerned, who's lean, who's non-obese. So here are the definitions. Lean is BMI less than 18.5 or 19 kg per meter square, and non-obese is between 19 to 24.9 kg per meter square. And we shall refer to this lean and non-obese throughout our presentation. Now, etiopathogenesis of such non-obese patients with diabetes is ill understood and possibly heterogeneous, as I shall illustrate in the presentation. And it is widely believed that non-obese patients with type 2 diabetes have greater insulin secretory defect or some other pathophysiology. Now, there are lingering questions and doubt. Non-obese patients, are they actually non-obese, or they have high body fat and ectopic fat, liver fat, for example? Are they, though non-obese, have insulin resistance? What about the glucagon? Lean patient, they have decreased insulin secretion or beta cell function? Why? And is there a hepatic metabolic dysfunction? Other causes: fibrocalculous pancreatic diabetes, lipodystrophies, LADA being missed in our patient, the masquerading as type 2 diabetes, and how to diagnose genetically determined diabetes. And how to approach such patients: same approach as obese patient, use of metformin, use of sulfonylurea, early insulinization. Now, I shall cover briefly these topics in my presentation. Now let's look at prevalence of lean non-obese patient with diabetes. And this is one of the best studies by Dr. Mohan. They classified lean as less than 18.5 kg per meter square BMI, which I showed you earlier. In the cohort of patients that they studied, only 3.5, look at this, 3.57% of the patients were lean. But lean patient had more severe hyperglycemia, more retinopathy, neuropathy, nephropathy, and 50% of them were controlled on OHA and 50% on insulin therapy. Subsequently, we published in 2003 a hospital-based study where we studied the body composition of patients with type 2 diabetes coming to All India Institute of Medical Sciences. And look at that. Even there, in the hospital-based study, we had 30% of the patients who had a BMI of less than 23, 48% had BMI less than 25, and we studied their body fat. Around 22% had normal body fat. So even 2 decades back, even hospital-based patients, there were plenty of patients who were non-obese and some were lean. In a well-characterized cohort of patients, 75 patients with a mean age of 28.9, so they were fairly young patients. And a BMI, look at the BMI, they were lower spectrum of BMI of non-obese and some were lean. 69% had type 2 diabetes. So even in these non-obese and lean patients, 69% had type 2 diabetes, 31% had autoantibody positive or presented with ketoacidosis. And in those patients who had type 2 diabetes, HOMA-IR were high. So meaning thereby that in this cohort of patients, non-obese patient, lean patient, the insulin resistance was high. Let's look at the differential diagnosis. This lists the differential diagnosis. So a non-obese or lean patient could be having a true type 2 diabetes. So BMI could be 19 to 24.9 or lean, they may be lean. So both of categories may belong to type 2 diabetes. Or they may be having autoimmunity. Now, we are not going to talk about type 1 diabetes, but LADA, late onset autoimmune diabetes, may be present. And genetically modulated diabetes, among them, the foremost is maturity onset diabetes of young, then mitochondrial mutation, lipodystrophy, and some unknown mutation. And the entity which I initially described, which was described by Professor M.M.S. Ahuja and Dr. J.S. Bajaj, malnutrition modulated diabetes mellitus, which actually was listed in the diagnostic criteria for diabetes earlier, is possibly not well characterized anymore, and the research is not very proper on this particular entity. Now, this is one of the first studies on heterogeneous etiologies of apparent type 2 diabetes in young people. Now, the patients here belong to 18 to 45 years of age, 268 patients, and look at this, what they found. They found familial partial lipodystrophy. It was just one patient, rare. 26 patients with LADA. So it is less rare, but maybe overlooked in adults. No patient with Modi here in general investigation. And 2 patients with mitochondrial variant of diabetes. And when they looked at the Modi carefully in patients who lacked insulin-resistant features, then they found 2 patients with Modi. Very interestingly, the average BMI of genetically based diabetes was less than 25, and antibody positive diabetes, they were slightly obese in this particular study. So this was a UK study, and let's see the study from India. This is again a well-characterized cohort from Lucknow, Dr. Ish Bhatia's group. They looked at 105 patients, age of onset of diabetes, fairly young, 18 to 35 years of age. And what they found was 40% each of type 1 diabetes and type 2 diabetes. And rest, 20%, 15% is fibrocalculous pancreatic diabetes, and 5% belong to heterogeneous other etiologies like Modi, mitochondrial diabetes, and flatbush diabetes. Let's look at each entity separately. This is LADA. This is onset at around 30 to 35 years of age with initial insulin independence. And they have presence of antibodies, BMI less than 25, and personal or family history of autoimmune disease. So, though the factors which may incite remain the same as for type 2 diabetes, excessive weight, smoking, physical activity, inactivity, etc. But most important is the genetic susceptibility, islet cell autoimmunity, and then subsequently insulin deficiency, and they slowly progress to insulin dependence. The fibrocalculous pancreatic diabetes, which if you remember, was found in 15% of the cohort of patients from North India. These patients have recurrent abdominal pain, and you can see the calculi right here, pancreatic calculi. They are present in the lean adolescent or young males. They have pain abdomen and steatorrhea, and there's a possible genetic link. SPINK1 is the gene which has been investigated. Their diabetes is brittle, they require insulin, though they may have low C-peptide, there is no ketosis. And rarely on the right side, you see the pancreatic cancer being reported from India in one of the patients with fibrocalculous pancreatic diabetes. So you must have the plain X-ray done in any patient with abdominal pain and diabetes and look at the pancreatic calcification. MODY is a huge subject by itself, but briefly, it is genetically and clinically heterogeneous subgroup of diabetes characterized by early onset of diabetes, usually before 25 years. Obesity and ketoacidosis are uncommon. Autosomal dominant, this is most important, inheritance, and primary defect is in beta cell function. 14 monogenic mutations have been identified, amongst them HNF and HNF1 alpha is the most common, and HNF alpha subtype and HNF4A subtype are very sensitive to effect of sulfonylurea. So this is something which needs to be looked into, and some of our patients which we actually treat as type 2 diabetes may belong to this particular diagnostic category. Now, this is a particularly interesting subject and very close to my heart because we have investigated this when I was in USA. Familial partial lipodystrophy, which is again an autosomal dominant syndrome. And if you see here, the excess fat deposition around the neck, and if you see the MRI of neck of this patient, full of fat versus MRI neck of a normal person. And there is the lipoatrophy of the limb and abdomen. So there's hardly any fat here in this particular area and excess fat in the neck. Onset of diabetes is before 20 years of age, and associated multisystem dystrophy and mutation is that of LMNA. And there are multiple variants of this particular syndrome. For example, this is one such study which shows that in 5,221 patients, one patient was found with mutation in PPR gamma. Now, this is another variant of familial partial lipodystrophy. This combination, these authors said that combination of BMI of less than 27 and high insulin requirement, if such a combination is occurring, the chances of finding lipodystrophy is high. Now, a rare syndrome, mitochondrial mutation, maternally inherited diabetes with deafness. Now, look at this. This is the locus here. And if the mother carries one gene, then the children may carry. Early onset of diabetes with impaired hearing before diabetes, lower BMI, more severe disease with a rapid progression of insulin dependence, and phenotypic heterogeneity with a mutation in this particular locus. This is the mutation. This is something which I was talking about. This is not very well characterized and probably less talked about recently. There's a history of malnutrition. Patient may require high doses of insulin, and even then, their leanness may not be corrected, and they may have infections, skin, soft tissue, pulmonary tuberculosis, and micro and macro vascular complications are rare. So you see, this publication is from 2002, and subsequently, recently, it has not been well investigated. Now, phenotype of lean patient with uh, a tip, type 2 diabetes. So we have till now talked about various other phenotypes and syndromes of apparent type 2 diabetes, but their etiology lies elsewhere. Here are the patients with type 2 diabetes. Now, they may be truly lean patient with type 2 diabetes. The phenotype is only partially characterized. They don't have protein deficiency or low socioeconomic strata, do not have autoimmunity. They have hyperglycemia with normal C-peptide levels and low insulin levels, and the authors have said that possibly hepatic extraction of insulin. They present with infections, peripheral neuropathy, macrovascular disease, less common, and sulfonylurea usually lead to good response. So again, this is something which needs further research. Now, non-obese patient, Asian Indians with and without diabetes, this is a phenotype which is commonly encountered. This phenotype is can be seen in non-diabetic people. This is one such study where Asian Indians, which were young Asian Indians with a non-obese BMI, they were investigated and compared with Caucasians. And look at this, their phenotype showed markedly high fatty acid, free fatty acid, low adiponectin, inflammatory markers, high liver and muscle triglyceride. So this is the typical phenotype of a young Asian Indian which develops into diabetes. And we have compared the young patients, non-obese patients, which are recently diagnosed to be having type 2 diabetes with non-diabetic control, and found a high amount of total abdominal fat. Look at this fat versus this. And also liver span is high, indicating high liver fat. This we published some time back. Further, so in such patients who have BMI less than 25, further weight loss is required, although their BMI may be in normal or upper limit of normal. Now, the same phenotype was further characterized by us, and we found that these non-obese patients, as compared to non-diabetic controls, had a marked insulin resistance and high C-peptide levels. And also, apart from high insulin levels, high OMA-IR, their fasting glucagon levels were high and correlated with multiple measures of abdominal obesity. So, non-obese patient, high body fat, high abdominal fat, high liver fat, high glucagon, high insulin, and high OMA-IR. In the same cohort of patients, the circulating DPP-4 levels were also higher than controls. And we all know that the circulating DPP-4 levels are injurious to multiple organ system, cause inflammation, insulin resistance, and also injurious to liver. There may be other pathways to diabetes in lean and non-obese individuals, especially Indian population. One pathway is through endocannabinoid receptor. Now, endocannabinoid receptors reside in the hypothalamus, and cannabis acts on these receptors, and they are blocked by rimonabant. And the obesity and nicotine cause overactivity of endocannabinoid receptor, which may lead to increase in the food intake, obesity, insulin resistance, and this is blocked by rimonabant. Now, rimonabant has been banned due to various reasons, but this is a pathway to insulin resistance which may occur in lean patients. And there is one evidence which exists that there is a high activity of endocannabinoid system in healthy lean Asian Indians. And look at this, as compared to Caucasians, and such patients may respond well to any ACS blocker, which may lead to less of insulin resistance. Similarly, if you look at brown adipose tissue, which is linked to obesity, insulin resistance, the higher the brown adipose tissue, the less is the insulin resistance and obesity. Look at this. On the left side is the image of the brown adipose tissue on FDG PET on cold stress mice. So this is a very small bit of adipose tissue. Not much is found in human beings. When South Asians were compared to white Caucasians, the white Caucasians had more of total BAT volume, meaning that thereby they have more of energy expenditure and they be more lean or insulin sensitive as compared to Asian Indians. So endocannabinoid system and brown adipose tissue needs more investigation as far as Indian population is concerned. Now, final two slides, very briefly, the management approach to diagnosis. So when you encounter a non-obese young adult patient with diabetes, if patient is lean, less than or equal to 19 BMI, then it could be young type 1 diabetes. And a star indicates family history may be or genetically determined or family history is present. Or patient may be truly lean type 2 diabetes or type 2 diabetes who has malnutrition or chronic disease of some type, or chronic calcific pancreatitis or SCPD with malabsorption. So these people can be truly lean. And when the patient is having a BMI between 19 to 25, it could be type 2 diabetes, it could be LADA. Again, the black stars indicate either genetic determination or family history. Lipodystrophies or genetically modulated diabetes like MODY or maternal diabetes with deafness. Now, general approach to treatment, I cannot be more detailed because of lack of time. But again, similar diagram, patient who's lean or has a BMI 19 or less, young type 1, obviously insulin, lean type 2 or type 2 with malnutrition, either sulfonylurea, insulin, pioglitazone, or DPP4 inhibitors, chronic calcific pancreatitis or FCPD with malabsorption, insulin is the something which should be given. Otherwise, some people may respond to metformin, pioglitazone, but certainly because of pancreatitis, DPP4 inhibitors should not be given. And a patient who has a BMI between 19 and 25, a typical type 2 diabetes, which will respond to multiple drugs, including SGLT2 inhibitors. And I would request all of you to put any patient who has a BMI of 23, 24 upper limit on SGLT2 inhibitor for them to benefit as far as their liver fat and total fat is concerned. LADA, metformin, DPP4, and insulin. MODY, some may respond to sulfonylurea diet and some to insulin. Lipodystrophy, pioglitazone, metformin, metreleptin, high-dose insulin, and SGLT2 inhibitors recently have been tried, and GLP-1 receptor agonist. So with that, I finish my presentation. I thank Dr. Banshi Chabu and his team for inviting me to present these data in front of you. Thank you.
Excellent topic, Dr. Anoop. We have got a very good insight about what are lean diabetics, what are non-obese diabetic, and how to manage those cases and what can be the differential diagnosis of those cases. So I think the question answer session is the last, so we can take up with the second session. So Dr. Deepak,
no, Dr. Saurabh, there are questions we can take with Dr. Anoop Misra.
Okay, sir, okay, sir. Okay, sir. Okay. So if there are any questions?
Sir, I would like one question which I want to ask. In one of the cohort which you talked about, there are almost 15% for a lean diabetes in North India.
This is the paper from Dr. Ish Bhatia's group, and in conjunction with multiple other investigators throughout the India, and the paper is labeled as patients from North India. They were, as I told you, around 100 patients, out of which 40%, these were young patients, they were non-obese patients, and the phenotype was type 2 diabetes in 40%, type 1 diabetes in 40%, 15% had chronic calcific pancreatitis or SCBD, and rest 5% had other types of diabetes. So this was the very well investigated cohort, perhaps the best one from India.
But
there
I mean,
are others
in clinical practice, you don't see so often in North and West India. I mean, in East India,
the FCPD.
FCPD. Yes.
You're right, absolutely. If you ask me how much I see, so I will probably respond to you by saying that less than 5%. If I say 100% of non-obese or lean diabetic, then 5% may have the FCPD. But this particular the study showed that it was 15%. I also showed you another study from UK where there was none. There was zero FCPD. So it may be more in certain part of India. It may be more once we are looking for it, and some may be missed also.
Sir, what about the subtypes of type 2 diabetes? I mean, we also classify these patients diabetes in young or severe insulin deficient diabetes if somebody is not investigating them for FCPD. And then we have a different class, which is obesity induced MOD or with SIRD. I was just, I want to ask you one question because Dr. Mohan had classified type 2 diabetes in the subtypes. One variety he had shown with a combined insulin deficient along with combined insulin resistance. I mean, both are in one group, while in a Sweden original paper, they had only 4 varieties where severe insulin deficient, severe insulin resistance, obesity induced, and age related. While in an Indian subtype, we had one more unique variety with a combined insulin deficient along with combined insulin resistant diabetes.
See, Banshi, I am aware of those data. For me, whenever I teach people or lecture people, I am very practical about what can be done, what should be done, and how we classify. If we say there are 5 types of diabetes, 7 types of diabetes, type 2 diabetes, the GPs will be very, very confused. So for me, there are 2 or 3 types. That's all. And we are developing some more data to tell you more about it, but there are some data which are available that I think the classifiers are only 2, BMI and liver. These are the 2 classifiers. By BMI, you can classify that the patient has insulin resistance or not, so BMI with acanthosis and so on. And by liver, you can further classify that this patient has more insulin resistance than others. So let's say one patient who's a lean patient, who's a BMI of 21 or say 20, and you palpate there is no liver, likely without any further investigation, you can say that there may be some insulin secretory defect here. And so you may treat him as such and be successful in your treatment 95% of the time. 5% you can be wrong. Now, if you look at another patient with a 27 BMI and you put a hand in the abdomen and you see 5 centimeter of firm liver, which I see every day, without even looking at ultrasound or a fibroscan, you can say that this patient is highly insulin resistant patient and that you need to throw him everything at him which will benefit his insulin resistance. A third type of patient, which also can be identified very well, and unfortunately, any of these studies have not taken that in consideration and looked at the various parameters, is acanthosis nigricans. If a person has acanthosis nigricans, there is no question that this patient will not be insulin resistant. And 99.9%. Unfortunately, in most of the currently treated patients, people do not even look at the neck. So by looking at phenotype and not looking at your insulin level, not looking at C-peptide, not further looking at any other investigation, you can very well characterize what you should do. So in a lean patient with insulin secretory defects, sulfonylurea or early insulin, and a patient who has a liver and insulin resistant, you can choose SGLT2, pioglitazone, metformin, all these combinations, and you will be successful. So Banshi, I think we have to be very practical in what we do in India, and that without going into any algorithm, just by looking at all these, you can decide very well and you will be successful in most of the time. Unfortunately, people don't characterize. That is the problem. That is the problem. They don't look at the neck and look at acanthosis. They don't feel the liver and characterize that.
This could be very great clinical approach wise fine. But sir, what you say about those advanced centers, should they get the C peptide? I mean, how clinically relevant to get the C peptide in a clinical practice? I mean, it is not required, or unless you just want to consider or classify someone as a pakka case of type 1 diabetes, except that does it have any clinical relevance to measure C peptide fasting and
No,
post?
it does have a clinical relevance. I'm not saying that C-peptide should not be done, but for example, say a person is very lean and with have marked hyperglycemia, it doesn't have ketoacidosis. You may do a C-peptide. Say C-peptide is not very low but low enough, and you may give early insulin in this patient. The second patient is, for example, let's say uh, chronic calcific pancreatitis or FCPD, where we often say what to do. A patient has a slightly high sugar. Some people say, well, give insulin. I will probably give metformin, some pioglitazone, not DPP4, not GLP-1. And most of the time, initially, I can succeed. But some patient may escape. And in such patient, a C-peptide may be done. And if C-peptide is low, you may say, well, we have failed with the oral therapy. Please, let's switch to insulin. In patients who, the third, which is a relevant point, is a patient with type 2 diabetes who has gone into ketoacidosis. And so there can be two, three ways to look at it. One is flat push type of diabetes, where they go into ketosis, they come out of it, and they respond to oral, and then they go into ketosis, then again come back. And the second one is patient with SGLT2 inhibitor have ketosis. In such cases also, C-peptide is going to be used. So any more questions?